If you can read this sentence clearly, you might still be losing 40% of your peripheral vision right now and not even know it. Glaucoma doesn't blur, it doesn't hurt, it deletes, quietly, year after year from the outside in, until one day you back into a parked car you didn't see, or you walk into a door frame in your own house, and only then does anyone run the test that would have caught it 10 years earlier. I'm a board-certified ophthalmologist. I've been managing this disease in my chair for 18 years. And in the next 20 minutes, I'll show you the 4 screening tests that catch glaucoma early, and the one most eye doctors still skip. I'm Dr. Jonathan Harris, board-certified ophthalmologist, 18 years in practice, and I've been the second opinion stop for more than a few patients who walked out of a routine eye exam with a clean bill of health and a glaucoma diagnosis 6 months later from somebody else. This is the disease where the screening conversation matters more than the screening itself, and I want to show you why. On this channel, I do something simple. I take the eye conditions that the typical 15-minute exam either rushes through or misses completely, and I show you what an eye surgeon would actually screen for in his own family, what the trade-offs really are, and what to ask the next time you sit in that chair. No affiliate pitches, no sponsored recommendations. If you want to keep your vision sharp into your 70s and 80s without losing the parts you'd never notice you were losing, hit subscribe so the next video shows up in your feed. Here's the route. First, why glaucoma is silent and what silent actually means at the level of your retina and your brain. Second, the trap that catches roughly 1 in 3 glaucoma patients in this country. The sentence, "your eye pressure is normal," that does not mean what most patients think it means. Third, the 4 screening tests that actually catch this disease early, with the one most exams still skip. Fourth, who is at higher risk and on what cadence you should be scheduled. Fifth, the modern treatment ladder, what the drops actually do, what the laser actually does, and the adherence catastrophe that quietly undoes most of it. And finally, the 5 questions you bring with you to your next eye exam that flush out whether the screening was real or routine. Let me show you why this disease is silent, because once you understand the mechanism, every other piece of this video makes sense. Glaucoma is, fundamentally, a disease of the optic nerve. The optic nerve is the bundle of roughly 1.2 million fibers that carries every visual signal from your retina to your brain. In glaucoma, those fibers die, slowly, quietly, in a specific pattern, usually starting in the periphery and moving toward the center over years. Now here's the first reason it's silent. Your peripheral vision is not a high-resolution image. It's a wide, low-detail awareness. Motion, contrast, looming shapes, and your brain is excellent at filling in the gaps from the other eye, from memory, from prediction. When you lose 10% of your peripheral field in the left eye, your right eye covers it. When you lose 20%, your right eye still covers most of it. Your brain stitches the 2 images together and presents you with a single, continuous picture. You feel like you are seeing normally because your brain is doing what it is designed to do, and what it is designed to do is hide damage. Now here's the second reason. Central vision, the part you use to read this sentence, recognize a face, drive a car, watch a screen, is preserved in glaucoma until very late in the disease. Central vision lives in the macula, served by a particular pattern of nerve fibers that are, in most forms of glaucoma, the last to be damaged. So you can lose 40, 50, even 60% of the optic nerve fibers in one eye, and your reading vision can still be 20/20. Your distance vision can still be 20/20. You pass the eye chart, you pass the screening. You walk out of the exam room thinking your eyes are fine. They are not fine. They are dying, at the periphery, where you cannot feel it, behind a brain that is actively hiding the damage from your conscious attention. Now we get to the central trap of this disease. The sentence that catches roughly 1 in 3 primary open-angle glaucoma patients in the United States. The sentence is, your eye pressure was 12, your eye pressure was 18, your eye pressure was 21. Your pressure is normal, so you don't have glaucoma. That sentence is medically wrong and has been wrong for at least 3 decades. Here is why. Eye pressure, intraocular pressure, IOP, is one of the major risk factors for glaucoma. It is not the disease. The disease is optic nerve damage. High pressure can cause optic nerve damage, lower pressure can cause optic nerve damage, and there is a specific subtype called normal tension glaucoma, sometimes called normotensive, where the optic nerve fibers die in a glaucomatous pattern, despite IOP measurements that always sit inside the so-called normal range of 12 to 21 millimeters of mercury. In the United States, normal tension glaucoma is roughly 30 to 40% of all primary open-angle glaucoma cases. Let me say that again with the punchline attached. About 1 in 3 patients walking around with progressive glaucomatous optic nerve damage will have a pressure reading that the screening exam calls normal. The mechanism is partly understood. In some patients, the structural support of the optic nerve at the lamina cribrosa is more fragile, so even normal pressure produces shearing damage at the fiber level. In some patients, blood flow to the optic nerve drops at night when the patient is lying flat, particularly in patients with low overall blood pressure, sleep apnea, or vasospastic disorders like Raynaud's, and the perfusion deficit at the optic nerve causes ischemic fiber loss. In some patients, central corneal thickness sits below average, somewhere around 500 microns, which makes the standard tonometer reading systematically underestimate the true IOP. So the patient is told a pressure of 17, but their actual pressure on a thinner cornea was probably 21 or 22. The patient hears normal. The eye is being damaged. The screening missed it. Here's what they don't tell you in the brochure. Eye pressure is one risk factor on a list of about 8, and screening for glaucoma by pressure alone in 2026 is roughly equivalent to screening for heart disease by blood pressure alone. You don't. You also look at cholesterol, family history, the EKG, the stress test, the symptoms. Glaucoma deserves the same workup. Most patients don't get it. All right, practical part 1. There are 4 tests that, run together, will catch the vast majority of glaucoma cases years before the patient feels anything. I'll go through them in the order I want them done. Test 1. Tonometry, IOP measurement. Standard, takes 30 seconds. Every eye exam in America does it. The number gets recorded. Test 1 is necessary, and Test 1 alone is the trap I just described. Do not stop here. Test 2. Central corneal thickness, also called pachymetry. A small ultrasound probe touches the cornea and measures the thickness in microns. Average is about 555. Below 555, your true IOP is being systematically underread, sometimes by 3 or 4 millimeters, which can be the difference between normal and glaucomatous on the same eye. Above 565, the true IOP is being slightly overread. Pachymetry costs the practice almost nothing, takes 90 seconds, and recalibrates your entire pressure history. This is the test most routine eye exams still skip, and the test that, if I were dictating screening protocols nationally, would become standard at every comprehensive eye exam after age 40. Test 3. OCT of the retinal nerve fiber layer, RNFL. OCT stands for Optical Coherence Tomography. It is a non-contact infrared imaging technique that produces a cross-sectional image of the retina at micrometer resolution. The RNFL printout shows you the thickness of the nerve fiber layer at every clock hour position around the optic disc. A normal eye has a characteristic double hump pattern: thicker superior, thicker inferior, thinner nasal and temporal. A glaucomatous eye starts thinning in the inferior or superior wedge, often years before the patient has any visual field defect they can perceive. OCT RNFL is the test that catches structural damage before functional damage. Most large practices have an OCT machine. Most patients over 40 should have a baseline RNFL on file. Test 4. Visual field, automated perimetry, usually a Humphrey 24-2 or 30-2 protocol. The patient stares at a central fixation light and clicks a button every time they detect a small flickering point of light somewhere in their peripheral field. The machine maps the sensitivity of every point in the field and produces a grayscale plot showing where the patient's peripheral sensitivity is depressed. Visual field is the test that catches functional damage, the actual experience of vision being lost. Combined with OCT RNFL, you have structure and function, the 2 pillars of glaucoma diagnosis. There is a 5th test I want to mention, gonioscopy, which is a special contact lens that lets the surgeon look at the anatomic angle where your iris meets your cornea. This is how we tell open angle from angle closure glaucoma, 2 completely different diseases that require completely different treatment, including emergent treatment for acute angle closure, which is a true ophthalmic emergency. Gonioscopy is part of a comprehensive workup, not a routine screening. There is one specific patient profile where every routine eye exam will measure normal pressure, the OCT will look borderline, the visual field will look unremarkable, and the patient will still progressively lose vision over the next 5 to 7 years. I will show you exactly that case at the 11-minute mark, and if you fit the profile, you need a different exam. Now, who needs which exam and on what cadence? There are 8 risk factors I want you to remember. Number 1, age. Glaucoma prevalence rises sharply after 50, climbs further after 60, and by 80 is meaningfully elevated. Number 2, family history, especially a first-degree relative. A parent or sibling with glaucoma roughly 4 to 9 times your lifetime risk depending on the study. Number 3, ancestry. African American patients have approximately 4 times the lifetime risk of primary open-angle glaucoma compared to white Americans, develop it earlier, and progress faster. This is statistical and well documented in the literature, and the implication is clinical, not social. The screening cadence should reflect the higher risk. Hispanic and Latino patients have approximately twice the risk of primary open-angle glaucoma after age 60. Asian patients have a higher rate of angle closure glaucoma specifically, which is a different risk profile. Number 4, high myopia. People with prescriptions stronger than -6 diopters of nearsightedness have a meaningfully elevated risk of open-angle glaucoma, partly because the structural geometry of the highly myopic optic nerve is more vulnerable. Number 5, steroid use. Oral steroids, inhaled steroids for asthma, even chronic use of steroid eye drops can raise IOP in susceptible patients, a phenomenon called steroid responsiveness. If you have ever been on long-term steroids for any indication, the screening conversation should include this. Number 6, sleep apnea. Untreated obstructive sleep apnea is associated with optic nerve fiber loss through both pressure and perfusion mechanisms. Number 7, low overnight blood pressure or systemic hypotension, especially in patients on aggressive blood pressure medication regimens that drop nocturnal pressure too far. Number 8, previous eye trauma or eye surgery, including LASIK, which can change the corneal thickness in ways that distort future IOP measurements unless explicitly accounted for. Now the cadence. Average risk, age 40 to 55. Comprehensive eye exam every 2 to 4 years. Average risk, age 55 to 65, every 1 to 2 years. Average risk, age 65 and up, annual. African American patients should be screened starting at 35, comprehensive every 2 years through 40, then annual. Patients with a first-degree relative with glaucoma should start comprehensive screening with OCT and visual field at age 35, regardless of other factors. Patients on chronic steroids, talk to your eye doctor regardless of age. Patients with diagnosed sleep apnea, the screening conversation includes glaucoma. None of this is dramatic. All of it is the standard of care. Most of it does not happen at the routine 15-minute eye exam. Let's talk treatment, because the goal of treatment in glaucoma, I want to be very precise, is to slow or stop optic nerve damage. We do not cure this disease. We do not regrow lost nerve fibers. The fibers you have lost are gone. What we do is preserve what is left, and we are good at preserving it when we catch the disease in time. The treatment ladder has roughly 4 rungs. Rung 1, eye drops. The first-line drop family in the United States for almost every adult open-angle glaucoma patient is the prostaglandin analogs. Latanoprost, sometimes branded Xalatan, bimatoprost branded Lumigan, travoprost, tafloprost, and the newer latanoprostine Bunode. They are dosed once a day at bedtime. They lower IOP by improving the outflow of fluid from the eye, typically by 25 to 35% from baseline, which is the largest effect of any drop family. Side effects are mostly cosmetic. Slight darkening of the iris in some patients, longer eyelashes, occasionally redness or pigmentation around the eyelid skin. Other drop families include the beta blockers like timolol, the alpha agonists like brimonidine, branded Alphagan, the carbonic anhydrase inhibitors like dorzolamide, branded Trusopt, and brinzolamide. Most modern regimens use combination drops to reduce the number of bottles a patient has to manage. Combigan, Cosopt, Simbrinza, and the newer Rocklatan. Rung 2, selective laser trabeculoplasty, SLT. This is a low-energy laser that targets the trabecular meshwork, the drainage tissue at the angle of the eye, and improves outflow without damaging the surrounding tissue. The LIGHT trial, published in 2019 and still the major reference, showed that SLT works as well as a single eye drop as a first-line treatment for newly diagnosed open-angle glaucoma in most patients. About 75% of patients reach target pressure on SLT alone at 1 year without any drops. SLT can be repeated. SLT does not have the adherence problem that drops have, and that is the next rung setup. Rung 3, minimally invasive glaucoma surgery, MIGS. These are microstents and channel-creating procedures usually performed at the time of cataract surgery. The iStent, the Hydrus microstent, the Omni canaloplasty, the Cahook dual-blade goniotomy, and several others. They lower pressure modestly, around 3 to 4 millimeters of mercury on average, but they often allow a patient to come off 1 or 2 of their drops, which has a real quality of life effect. If you have mild to moderate glaucoma and you are scheduled for cataract surgery, you and your surgeon should be having an explicit conversation about combining a MIGS procedure into the same operating room visit. Rung 4, incisional surgery, trabeculectomy, or tube shunt. These are full operating room procedures for advanced or treatment-resistant glaucoma. They lower pressure aggressively but carry meaningful complication profiles. They are not the first line, they are the rescue. Now, the adherence catastrophe. About 50% of patients prescribed glaucoma drops are not taking them as prescribed at the 6-month mark. Some forget. Some stop because the bottle is irritating. Some stop because they feel fine, which is the silent thief problem closing the loop. The drop is preserving vision they cannot feel themselves losing, so the daily reminder of the drop feels disproportionate to the felt benefit. They stop. The disease progresses. They come back 2 years later with a worse visual field. This is the single largest reason patients on technically adequate prescriptions still go blind from glaucoma in the United States. And here is why I introduced SLT and MIGS in that order. SLT moves the patient out of the daily drop adherence problem entirely. MIGS reduces drop burden. The treatment ladder is not just about lowering pressure. It's about lowering pressure in a way the patient will actually sustain over the next 20 years. Let me make this concrete. Linda P., 64, retired schoolteacher, lives in Philadelphia. Came to a colleague for a second opinion 3 years ago after she backed her car into a hedge in her own driveway, twice in 1 month. She had passed every routine eye exam she had taken for the previous decade. Her chart said her eye pressure was 16, 15, 17, never above 18, always inside the so-called normal range. She was not diabetic. She had no family history of glaucoma she knew of. She wore glasses for moderate myopia. She had 2 pairs of readers. She thought she was fine. We ran the 4 tests. Her IOP that day was 17, normal. Her central corneal thickness was 510 microns, meaningfully thinner than average. The instant we corrected her 10-year history of pressure readings for her actual corneal thickness, every reading shifted upward by about 3 to 4 millimeters. Her real lifetime IOP exposure had probably averaged closer to 20 or 21, high normal at best, not the comfortable mid-teens her chart had been describing. Her OCT RNFL was the more striking finding. Both eyes showed clear inferior wedge defects. The fiber layer thinned dramatically in the 5 to 7 o'clock sector of the optic disc, deep into the red zone of the normative database. Left eye worse than right. Her Humphrey 24-2 visual field confirmed it, a superior arcuate scotoma in the left eye, the corresponding region of peripheral field that the inferior nerve fibers serve, with sensitivity dropped by roughly 30%. She had been losing fibers in that pattern for somewhere between 5 and 10 years. Gonioscopy showed a wide open angle, confirming primary open-angle glaucoma, normal tension subtype. Her prior eye doctor had never run a Perimetry on her, never run an OCT RNFL, and the visual field had been a brief screening rather than a full Humphrey. The tonometer reading had been clean every year. The chart had said normal every year. Linda did not have a complication. Linda had been silently losing optic nerve fibers for a decade behind a screening that was not built to detect what was actually happening to her eye. We started her on a once-a-day prostaglandin analog drop, latanoprost. Her IOP dropped from 17 to 12 at 2 months. Subsequent OCT scans show stable RNFL thickness. No further loss in the 18 months since starting treatment. The fibers she lost are gone. The fibers she has left are now stable. That is the realistic best outcome for a missed normal tension diagnosis caught in the 7th decade of life. Earlier would have been better. Earlier would have required a different exam. Quick second case, and this one goes the other direction. Tom B., 55, real estate broker in Boston. African-American patient, father went blind from glaucoma at age 70. Tom came in at 53 specifically because of family history. He didn't have symptoms, he had a question. We ran the 4 tests. His IOP was 22 in the right eye, 19 in the left, high normal in the right. His central corneal thickness was 540 microns, slightly thin, modestly under-reading his pressure. Corrected, his right eye IOP was probably closer to 24. His OCT RNFL showed early thinning in the inferior quadrant of the right eye, just into the borderline yellow zone of the normative database. His Humphrey 24-2 was unremarkable. No measurable functional defect yet. Gonioscopy showed open angles. He had structural early damage on OCT before any visual field defect, and a high normal pressure on a moderately thin cornea. Combined with his ancestry, 4 times the lifetime risk, and his first-degree family history, another 4 to 9 times on top of that, the diagnosis was straightforward. Early-stage primary open-angle glaucoma, right eye worse than left, caught structurally before functional damage. We started him on a once-a-day prostaglandin analog drop, bimatoprost in his case. His IOP dropped to 14 and 15. We discussed selective laser trabeculoplasty as an alternative to lifelong drops. He chose to try the drop first and reconsider SLT in a year. He came back at 3 months, 6 months, and 12 months. OCT stable. Visual field unchanged. He is now in the 4th year of treatment. He has not lost a measurable square millimeter of visual field since diagnosis. Tom did exactly 2 things differently from Linda. Tom asked his eye doctor a different question. He came in saying, "My father went blind from glaucoma. What should I be screened for?" And the eye doctor responded with the 4 tests instead of the 1. Tom got the OCT before he had any symptoms. Tom got the Perimetry before anyone gave him a verdict on his pressure. Tom is not a more careful patient than Linda. Tom is a patient who got the right exam 10 years earlier in his life. The difference between Linda's outcome and Tom's outcome is not the surgery. It is the consult. Now, practical detail that most patients are never taught. If you are on glaucoma drops, the technique matters as much as the prescription. There are 5 steps. Step 1, wash your hands. Step 2, tilt your head back, pull the lower eyelid down to create a small pocket. Step 3, instill 1 single drop into the pocket. The eye holds about 30 microliters of fluid. The drop bottle delivers about 50. A second drop overflows down your cheek and reduces the dose absorbed by the eye. 1 drop. Step 4, close your eyes gently for 60 seconds. Do not blink the drop out. Do not squeeze. Just close gently 60 seconds. Step 5, punctal occlusion. While the eyes are closed, press a clean fingertip to the inner corner of each eyelid, where the tear duct exits to the nose. Hold for 60 seconds. This blocks the tear duct drainage that would carry the drop into your nasal mucosa, into your throat, and into your bloodstream, which is both wasted dose and the source of most systemic drop side effects, including the bronchospasm that beta blocker drops can trigger in patients with asthma. 5 steps, 2 minutes total, twice the effective dose at the eye. Most patients have never been shown this. The adherence problem is the second half of this conversation. About 50% of patients prescribed a glaucoma drop are not taking it as prescribed by the 6-month mark. The reasons stack. The bottle stings. The drop tastes bitter at the back of the throat because the punctal occlusion was skipped. The eyelashes feel different. The patient feels fine and the daily ritual feels disproportionate. The patient is on 3 other medications and 1 more bottle is 1 more friction point. The cost stacks even with a generic. The patient stops. The pressure goes back up. The optic nerve resumes losing fibers at the same silent rate it was losing them before treatment. There are real workarounds. The most important is the conversation with your eye doctor about whether selective laser trabeculoplasty would be appropriate as a first-line treatment in your case, because SLT moves you out of the daily drop adherence problem entirely. The second is once-daily dosing. Most prostaglandin analogs are once a day at bedtime, which is meaningfully easier to remember than twice or 3 times a day. The third is preservative-free formulations for patients with surface irritation, which removes the back preservative trigger for chronic redness and burning that drives many patients to abandon their drops. The fourth is combination drops that consolidate 2 or 3 medications into a single bottle. None of this is exotic. All of it is a conversation. Most patients never have it. All right, practical part 2. Here are the 5 questions you bring with you to your next comprehensive eye exam. Write them down. Ask them in order. If your eye doctor cannot answer any of them, that is a useful piece of information about whether the screening you just had is the screening you needed. Question 1. What was my central corneal thickness today, and how does it adjust the interpretation of my eye pressure? If they did not measure Perimetry, they cannot interpret your IOP correctly. This is the test most exams skip. If you have never had a Perimetry on file, ask for one. Once it is on file, your future pressure readings recalibrate against it forever. Question 2. Do I have an OCT of my retinal nerve fiber layer on file? And what does the inferior and superior wedge look like? Most modern practices have an OCT machine. If you are over 40, you should have a baseline RNFL on file. If your practice does not have one, ask whether they refer you out for the imaging. Most will. Question 3. When was my last formal Humphrey visual field test, and what was the pattern? Not the brief screening field, the formal 24-2 or 30-2 protocol. If the answer is never, or I am not sure, that is a reason to schedule one. Question 4. Given my age, ancestry, family history, and refractive error, what should my screening cadence be over the next 10 years? Make them put a number on it. Every year, every 2 years, every 4 years. The cadence should be specific to your risk profile, not generic. Question 5. And this is the question that flushes everything out. If I had a first-degree relative with glaucoma, would the screening you just ran on me be the screening you would run on yourself? That sentence is your single best diagnostic for whether the exam was a real workup or a routine 15-minute glance. A genuine answer often ends with, we would also want a perimetry and an OCT and probably a Humphrey on file. That answer is honest. The routine answer is not always wrong, but it is rarely the screening the eye doctor would do for their own family. Listen for that gap. It tells you everything. Let me close the loop on the whole thing. Glaucoma is silent because your peripheral field has low resolution, your other eye covers most of the loss, and your central reading vision is preserved until very late. 40% of one eye's optic nerve fibers can be gone before any patient on the planet would notice. The screening problem in this country is that the routine eye exam still leans heavily on a single number, eye pressure, and 1 in 3 open-angle glaucoma patients in the United States have a pressure number that the screening calls normal, while their optic nerve is dying. The 4 screening tests that change this conversation, tonometry, perimetry, OCT, RNFL, and a formal Humphrey visual field, are not exotic, are not expensive, and most modern eye care practices already own the equipment. The test most routinely skipped is perimetry, and perimetry is the cheap one. The treatment ladder works when you start it early enough. Drops, selective laser trabeculoplasty, MIGS at the time of cataract surgery, and incisional surgery only at the top of the ladder for advanced disease. The adherence catastrophe, 50% of drop-prescribed patients off their drops at 6 months, is the single largest reason patients with technically adequate prescriptions still progressively lose vision. Selective laser trabeculoplasty is the most under-discussed first-line option in modern glaucoma care, and the conversation about it should happen at every patient's first diagnosis, not as a backup after the drops fail. Here's what they don't tell you in the brochure. Glaucoma is not a single disease. It is a family of optic nerve diseases that share a final common pathway, and the screening that catches them in time is a different exam from the one most patients receive at their routine annual visit. I do this work in my chair every week, 18 years. The patients who keep their vision into their 70s and 80s are the patients whose first comprehensive workup happened 10 years before any symptom. The patients who lose vision are the patients whose first comprehensive workup happened after they backed into the parked car. If a surgeon or eye doctor tells you, your pressure is normal, you don't have glaucoma, without showing you a perimetry number, an OCT RNFL printout, and a recent visual field, walk out and get a comprehensive workup somewhere else. That is not aggressive. That is medicine. If you've ever been told your pressure is normal, and that was the entire glaucoma conversation at your eye exam, do me a favor. Drop a comment below with your age and whether you've ever had a perimetry, an OCT, or a Humphrey field on file. I read every single one. If you found this useful, hit like. It tells YouTube to push it to the next person who's sitting in front of an eye chart this week with a family history they haven't told anyone about. And subscribe, because next week I'm going deep on the part of this conversation I left unfinished, the adherence catastrophe. Roughly half of glaucoma patients prescribed drops are not taking them as prescribed by the 6-month mark, and most of them genuinely don't realize they've stopped. Next video, we walk through why adherence breaks down, even in motivated patients. The specific bottle handling and timing fixes that double real-world effective dosing. The case for selective laser trabeculoplasty as a first-line conversation in patients who already know they will struggle with daily drops. And the 4-question conversation to have with your eye doctor when the prescription does not match how you actually live. Take care of those eyes. They're the only pair you've got.